Hi, my name is Jennifer Johnson. I'm one of the physicians in the Division of Infectious Disease here at Brigham and Women's Hospital, and an assistant professor of medicine at the Harvard Medical School. Today we're going to talk about HIV disease. This is an overview and a welcome invitation to talk about a virus other than COVID-19 right now. I have no financial disclosures. And this is just a brief outline of what we're going to cover. We're going to talk about the current epidemiology of the HIV epidemic and public health goals, the current state of HIV testing, current recommendations for initial antiretroviral therapy, approach to complications of HIV and aging with HIV, and current approaches to HIV prevention. So I put in a few slides here to talk a little bit about the epidemiology of the epidemic, because unfortunately the epidemic is really ongoing in the United States, despite, even despite really a lot of advances in care for patients with HIV and HIV prevention. Unfortunately, we're still seeing, a nearly steady number of new incident cases year by year. And this graph shows the cases over the last 7 years for which we have CDC data. And you can see that there's been a slight decline in new incident cases, but not really significant. We're almost in a plateau here. And in fact, we're still seeing close to 40,000 new cases per year. And amongst those, this is a little bit of a breakdown of the demographics of patients who acquired HIV and the route of exposure. Nearly 70% were among patients who are gay, bisexual, and other men who have sex with men. 24% were by sexual exposure with partners that were heterosexual. And only a small percentage were among people who inject drugs, so 7%, definitely the minority of new cases. And the new incident cases are definitely predominantly in young people. And you can see that there's a large majority of the new cases were actually in the age group of 25 to 34 years old. So this is all to help you think about when you're seeing new patients in clinic, or actually long-standing patients even, which of your patients may be more likely to fall into these higher risk groups. And in fact, the most infected subpopulations disproportionate to their representation in the general population are listed here. And you can see Black or African American male-to-male sexual contact is really a large number of cases, despite making up only a small fraction of the general population. This is really disproportionate to the demographic split that we see amongst the general population. So really a very, very high risk group, and Hispanic or Latino or Latinx male-to-male sexual contact is similarly disproportionately large representation in new incident cases. And I mentioned earlier that transmission through injection drug use has been, over the last several years, has been very low. But we have seen these outbreaks in many places in the United States. Probably people will remember there was a lot of press several years ago with the HIV outbreak that occurred in rural Indiana associated with injection use of a synthetic opioid called the brand name Opana. But there have been multiple other outbreaks, both in the US and internationally. There's several international cities listed here that were presented at the AIDS conference back in 2018, and multiple outbreaks in our area here in Massachusetts, north of Boston initially, and then actually down in Boston as well. And so we've really noticed that there has been a little bit more of a collision or overlapping of the opioid epidemic and epidemic of injection drug use overlapping with the HIV epidemic in certain areas at certain times. And so it's worth being aware of what's going on in your own area, and whether or not injection drug use may be associated with a much higher risk of HIV due to a particular epidemic or outbreak in your area. That should prompt people to do more frequent testing, and also to look for acute infection even in patients who may not have specific symptoms. So looking at where we hoped to be already, or where we're hoping to go. So some of the public health goals that were put out, this one in particular by the UNAIDS, but this is, sort of a similar goal to most international agencies at this point, is this 90-90-90. So this idea that the goal would be that 90% of patients in any a country population would be aware of their HIV status, which obviously can only be achieved by really widespread rollout of testing. And then of those who are aware of HIV status, 90% would be on HIV treatment, and of those 90% would be virologically suppressed. And that should actually lead to a significant drop in new HIV infections annually. And that is a goal. This is where we're at least as of 2016, which is the last year that we have this particular type of data. So 6 in 7 patients knew of their HIV status, HIV positive status within the United States, out of an estimated 1.1 to 1.2 million people living with HIV in the US. Only 64% actually were receiving any HIV care, and only 49% were actually retained in care, so came to multiple visits or stayed connected with any type of care, and only 53% were biologically suppressed. So we're unfortunately still quite a ways away from that 90-90-90 goal. But all of the parts of the remainder of what we're going to talk about in this talk are things that help us to get there. So how to do more effective testing, how to then try to engage patients in care, and how to prescribe appropriate antiretroviral therapy. And then, of course, preventing the need for the 90-90-90 at all is, HIV prevention measures to prevent patients from becoming infected in the first place, part of which this will help with, but many other measures to try to prevent patients from acquiring HIV in the first place. So now we're going to talk about HIV diagnosis and a test for HIV diagnosis. And I'm going to, before I get into describing the details of what's apparent on this slide, which is a bit complicated, I'm just going to emphasize a couple of points. The first most important thing when thinking about how to approach somebody for HIV testing is actually to have thought of it at all. So to remember that HIV testing is an important part of many healthcare interactions in many different healthcare settings. Both for screening, incredibly important, and to remember that it's a part of primary care, and second, to remember that it's a part of diagnostic care for patients presenting with a number of symptoms that can be really widely varied, and it's an easy, low-cost test that's usually incredibly accurate and non-invasive, and very important in terms of preventing potentially fatal illness for patients by diagnosing as early as possible. So that's actually the most important point here, is that HIV testing is an important part of medical care in many different settings, including primary care, and it should be a part of your sort of healthcare maintenance list for patient visits, for adult patient visits. And the second most important thing before we talk about the details is that in most settings, doing an HIV test is actually a little more straightforward than what it looks like on this chart, because you're really just looking to test a patient for HIV that may have been acquired at some time in the past, probably longer than several weeks ago, in almost all cases, with very few exceptions. And in that case, whichever test is offered at your institution, which may be the 4th generation immunoassay, which is bolded in a bold red circle here, which is our current standard of care, or may still be an older antibody test. Either way, those tests are going to be effective for almost all cases. And then only in rare exceptions do we need to think about additional testing for viral. So getting now into the details of this graphic here, if we look at the horizontal axis here, all the way to the far left is time 0, which is the time at which a patient may have been exposed to HIV infection. And for the first week to 2 weeks, now these aren't exact days, number of days, of course, but for the first week to 2 weeks after exposure to HIV infection, a patient, the HIV virus itself will be reservoired in the local lymphoid tissues adjacent to where the patient may have acquired infection. So that's typically in the anogenital area, and won't be accessible through the blood or systemically. And so there's no test that actually can diagnose HIV infection during that time period. And in fact, during the first 72 hours after exposure to HIV is when we actually have an opportunity to access it in those limited areas with antiretrovirals and potentially prevent the development of chronic infection and by the use of post-exposure prophylaxis. So that's this eclipse period. And after that eclipse period ends, there is a burst of viremia, which is the solid line that goes up quite quickly here on the graph. And that would be detectable by testing for the HIV viral load, typically done as a PCR test for the HIV RNA. And that's the test we would use in somebody who we suspect of having acute HIV infection. Even if your center has this 4th generation immunoassay, you can see the first thing detectable on that assay, which is a combination antigen and antibody test, the first proportion of that test that would show positivity would be the P24 antigen component, which doesn't start to rise until a little bit after the viral load starts to rise. So there's still an indication to test for the viral load as a diagnostic test for new HIV infection if you suspect that the patient has symptoms of acute HIV. But very quickly thereafter, the P24 antigen does rise, and then not too long after that, probably in the couple of weeks range, potentially shorter, variable patient to patient, the HIV antibody also will rise. And so this viral detection 4th generation immunoassay is incredibly helpful for looking at both of those components to help make sure that we have a high sensitivity and specificity test. The older antibody detection alone tests, even the 3rd generation immunoassay wouldn't show positivity until a little later because it doesn't include the P24 antigen, and also has a potential lower specificity by not including the P24 antigen if there's any reason for a false positive. But all in all, we have great tests. Again, they're quite useful, so definitely test your patient for HIV. And if you're able to make an HIV diagnosis, the next thing we're usually talking to patients about is about prognosis and treatment. And fortunately, the prognosis discussion is actually usually a really happy one. This is also, unfortunately, a bit of a busy slide, and I apologize about that. But it's to get the point across that any gap in life expectancy for patients with HIV as compared to patients without HIV has been narrowing significantly over time. You can imagine that these lines were even more divergent prior to the year 2000. We've sort of cut out that time period just for brevity here. But even within the last 16 years that's shown on this graph, or the last 20 years since this graph began, we've seen that there's been a minimizing of the gap in life expectancy and for patients with HIV, so that's in the dotted lines here, as compared with patients without HIV. So you can see the differential here is becoming smaller and smaller, as compared with, unfortunately, we do see ongoing life with comorbidities that is not actually improving significantly for patients with HIV as compared with patients without HIV. But if we control for a couple of factors, which is done in this study, by the way, was done at Kaiser Permanente out in California with an enormous database of patients followed over an incredibly long period of time, and looking at overall survival after diagnosis with HIV and a number of different comorbidities, and also paring down to look at patients who started on antiretroviral therapy at different CD4 cell count strata. And in this particular graph, they've actually looked at patients who initiated antiretroviral therapy, that's that ART there, with a higher CD4 count, greater than 500. They had a significant improved comorbidity-free life expectancy for cancer and cardiovascular disease. Still, unfortunately, the HIV, even at a high CD4 cell count initiation, seems to still affect diabetes and liver, kidney, and lung disease, but otherwise is actually improves life expectancy without cancer and cardiovascular disease, and alleviates the gap in overall life expectancy. So if we are able to diagnose patients early enough that we catch them when their CD4 cell count is still quite high, so 500 or greater, and start them on antiretroviral therapy at that point, then we can actually expect them to have the same length of life as a patient without HIV. And that's really incredibly positive news. And it's a good reminder of why it's so important to test patients routinely as a part of their ambulatory primary care in order to find those diagnoses early when patients are asymptomatic, and be able to get them on therapy and make sure that this, if this disease is found, it's not something that affects their life expectancy. Okay. So with that in mind, this is our first, we have 2 cases. So this is a 26-year-old young man coming for a clinic visit for a new HIV diagnosis. So the way this happened was 2 weeks prior, he had STI testing because he had developed rectal discharge. And this was positive for gonorrhea by a nucleic acid test that was done on a rectal swab appropriately. And on that day, because he was concerned about STIs, the provider appropriately also did HIV screening, and that was positive. And he was treated with intramuscular ceftriaxone and oral azithromycin for the rectal gonorrhea. And he also then received laboratory testing after his HIV antigen antibody test was positive. And the labs showed a CD4 cell count of 470, HIV-1 viral load of 12,743, no resistance mutations, syphilis serology, hepatitis C antibody, and hepatitis B surface antigen were all negative. So which would be appropriate at this point, at this visit? We have these labs back we're discussing. So A, initiate antiretroviral therapy with tenofovir, emtricitabine, bictegravir. B, initiate sulfamethoxazole trimethoprim daily for prophylaxis and to ensure medication adherence, and have him return in 6 months to discuss ART at that time. C, initiate post-exposure prophylaxis with tenofovir, emtricitabine, and raltegravir for a 28-day course. Or D, no medications right now, follow up in 12 months for repeat blood work. So the answer in this case is A, initiate antiretroviral therapy with tenofovir, emtricitabine, and bictegravir. And I just have an explanation of it here. So all patients with HIV should be offered antiretroviral therapy. However, evidence supports the benefits of initiation of ART even at high CD4 cell counts, and the risks of drug resistance and ART toxicities are incredibly low. And also from the public health perspective, this also decreases his risk of transmission to others, and we know that he's someone who's already just acquired another STI from someone else, so there's definitely a concern about potential transmission. The sulfamethoxazole trimethoprim prophylaxis for PCP, which is what we would potentially use that for, is not necessary or of any benefit at his high CD4 cell count. And there's no evidence to support a test of adherence, like using some medication to make sure that somebody takes their medications regularly prior to giving them antiretroviral therapy. It would not be reasonable to give him post-exposure prophylaxis. He's far too long, has established HIV infection, so post-exposure prophylaxis is not going to prevent the development of established infection. And 12 months is far too long to wait for follow-up. There's actually quite a bit of data to support the idea of a same-day start when patients are diagnosed with HIV. So would potentially have been even before we had a lot of those labs back that he has had returned. And so, you know, we certainly have enough information absolutely at this time to start antiretroviral therapy for this patient. So I already gave away the answer to this question, but the question is, who should be treated with antiretroviral therapy? And of course, it's all patients with HIV. But we do have a little bit of differentiation in terms of how we want to approach with the patient if the patient maybe has some hesitancy or some reason that they're not ready to start antiretroviral therapy at this exact moment. So the timing of it, again, we are very open to starting antiretroviral therapy as a same-day start for patients who are healthy and willing to go ahead and get started on that. And we do use that approach frequently, but we don't always want to necessarily feel that we need to push that in the same day for all patients. We do need to start antiretroviral therapy urgently for patients who are at risk of AIDS-related complications, if they have a low CD4 cell count or have a current opportunistic infection. Once they're receiving some treatment for their opportunistic infection, we want to start within 2 weeks, which may be while the patient is still in the hospital, if they're hospitalized for that opportunistic infection. We want to start urgently for patients who are pregnant, especially if they're in the second trimester or beyond, or others who are at high risk of transmission, because we know that treating a patient with HIV, both for pregnant women and for others who maybe have sexual partners or patients, other people that may be exposed by bloodborne exposure, if we treat the patient who is HIV infected, we prevent transmission to others very effectively. In the setting of acute HIV, early treatment may help to stave off some of the loss of lymphoid tissue and the CD4 cell count drop in that particular setting. And patients who are co-infected with hepatitis viruses, because those viruses can worsen progression of HIV and vice versa. And if there are any other HIV-related complications that may not be related to CD4 cell count strata, such as HIV-associated neurocognitive disorder or HIV-associated nephropathy. But in patients who are asymptomatic, have a high CD4 cell count, and not currently pregnant, they don't absolutely need to start antiretroviral therapy same day. It is ideal to make sure to communicate to the patient that when we start antiretroviral therapy, we need for it to be a lifelong therapy. We know that stopping and starting antiretroviral therapy is associated with an increased risk of complications, including cancers. And so our ideal situation is to start and continue lifelong. There may be switches between different medications, but that our ideal situation is for patients to be on some sort of continuous antiretroviral therapy lifelong. So that's a discussion to have with a patient when you're starting medication, to make sure that, that they understand. And there are some situations where there may be other priorities that need to be dealt with prior to initiation. So which drugs to choose? There are so many options. We had still using a relatively stable structure for our initial regimens in terms of types of drugs for the most part. So most of our first-line regimens still include 3 antiretroviral agents from 2 different classes. And that's actually been the regimen structure for first-line regimens since the mid to late 90s, since the advent of combination antiretroviral therapy. Typically 2 nucleoside or nucleotide reverse transcriptase inhibitors, or NUCs, along with a third drug. And the third drug options would be a non-nuc, an integrase inhibitor, or a boosted protease inhibitor. We do have a new 2-drug first-line regimen. We've had multiple situations over the last decade in which 2-drug regimens have been tried and been shown to be not as effective as 3-drug regimens until we have this regimen that includes an integrase inhibitor, which is dolutegravir, along with a nuc, which is lamivudine. And that combination has been shown to be just as effective as a 3-drug regimen for initial therapy for HIV, as long as the patient has an HIV viral load that's not super high, so below 500,000. It's been proven that the patient does not have concurrent hepatitis B infection, because in that case, they would require 2 agents that are active against hepatitis B, and would in this regimen only have 1 with lamivudine. Typically, the second nuc provides that activity. And in patients that have HIV resistance testing, which shows no resistance to the nucleoside or NUCs. So this is a great option for some patients to sort of minimize exposure to additional agents if it's not necessary. And how do we pick all of our regimens from specifically which regimen to start? We are almost in an embarrassment of riches sort of situation now with antiretroviral therapy options. So this slide actually is made up only of single tablet regimens. So each of the medications that's pictured here is a single pill that contains a full antiretroviral regimen that a patient can take once daily to receive their entire antiretroviral regimen. And it's just amazing that at this point we have so many options to treat HIV with a relatively simple and straightforward treatment process. Now, they do have to continue lifelong. We don't have a cure yet, but it really is amazing to have options like this to offer to patients. And each of these regimens contains medications that have very slightly different side effect profiles, slightly different risks for potential drug interactions, and patients, may have slightly different reactions to them in terms of what mentally and physically feels like the best fit. But for the most part, we were able to find a regimen that fits for most patients, even just within this single tablet regimen options, which was really a tremendous advance. And if we do need to move to a multiple tablet option, we have also all of these other options to put together a multiple tablet regimen that will have low toxicity and high efficacy, and find something that works well for the patient. So it's really a wonderful situation to be able to have so many options, and we really rarely find ourselves in a situation where it's difficult to put together a regimen that will work for a patient both from side effects and efficacy perspective. It's beyond the scope of this talk to really go through all of the drugs in these regimens and talk about them specifically, but I think there are a couple of key toxicities that are worth being aware of. Tenofovir is one of the nukes, and it previously existed in a form called TVF, or tenofovir disproxyl fumarate, and our newer formulation of tenofovir is tenofovir alafenamide. And the reason we have the newer formulation is that the older formulation was associated with a risk of nephrotoxicity and osteopenia after long-term exposure. This newer formulation has a lower risk of that, but still does carry some risk. So we do monitor for that and consider discontinuation if that becomes a problem. And we have a couple of agents, rilpivirine being the one that we use most commonly at this point, that are finicky about absorption. The rilpivirine requires to be ingested with a fatty meal, and and it needs some stomach acid around, so can be ingested when patients are taking antacids in order to be absorbed appropriately. And many of our drugs still, unfortunately, it's definitely better than previously, but many of our drugs still are associated with interactions with other medications that may affect absorption or drug levels, efficacy, and toxicities of other medications or of the antiretrovirals themselves. So it's just a reminder that if you have a patient who's on an antiretroviral, to make sure to check the drug interactions before you're starting any new medications for that patient. And I just put in here just a little graphic of the Micromedics Drug Interactions Program, which is the program that I tend to use, but really any drug interactions program to just check those interactions as you're adding a new medication, or if you're concerned about issues, is always a smart thing to do. I just wanted to mention that specific to one of our antiretroviral agents, dolutegravir, which is an agent that's currently not in co-formulations, but it's something that we use quite commonly in combination with tenofovir emtricitabine tablets, so as a 2-tablet regimen. Dolutegravir is an incredibly effective drug and low toxicity in general, but there was some concern raised in 2018 and through today, basically about the possibility that it could have some teratogenic effect. The data actually shows that that is a little bit unclear to the degree to which this is actually a real risk of harm for patients. There were 4 babies basically in which the moms had been exposed to dolutegravir around the time of conception or early in pregnancy, who were born with spinal cord defects in Botswana, which is a country that doesn't actually fortify its grains with folate. And so there's some concern about the potential increased risk in that particular population. And then after a more long-term follow-up of that population, there were no subsequent birth defects. So the signal was a little bit above the baseline background signal, but then did not persist. So the data is a bit unclear. There is a hesitancy warning about that drug for this particular reason. It's the only one of our active agents that we prescribe right now for HIV that carries a teratogenicity concern. But again, the data is a little bit unclear about it at this point. So we just talk about it with our patients and avoid it in women who are of childbearing age, and not using any birth control if there are other options that are equally efficacious for the patients. And this is a bit more about that data, which I just explained, but comparing to another agent called efavirenz, and essentially showing that there really isn't a significant issue in terms of risk with dolutegravir later in pregnancy, especially. Okay, so what about patients who are on one of these medication combinations and develop, unfortunately, treatment failure, which we would define as somebody who has been taking, been prescribed antiretroviral therapy that we would have hoped was effective, and subsequently has laboratory monitoring that shows that their viral load is detectable or at a significant amount. So something more than just a very low, very, very low level detection. So sometimes we'll put a threshold of maybe around 200 copies per ml. So the first measure that we usually take in approaching this is really to discuss adherence with the patients, because that's almost always the cause of an increased viral load, is that something is getting in the way of the patient actually taking their medication. And I think most people know this to be true in terms of patients taking many other medications, such as medications for diabetes and high blood pressure. We just have a very easy outcome measure with the HIV, because we can look at the viral load, and our medication regimens are so effective that if the viral load is up, it's almost always because the patient is not actually taking their medication effectively on schedule. And by on schedule, I really mean just that they're actually taking their medication sometime in the day, not at exactly same time every day, just sometime in the day, most days of the week. And that's actually really all it takes for most of these medicines, because the pharmacokinetics are so good and they're so potent. So this is just an open and honest conversation about that. In some situations, we do run into issues with drug-drug interactions. And we may worry about the development of drug resistance, especially if patients have had ongoing exposure to a non-suppressive regimen, so some antiretrovirals and also some virus at the same time. So this is typically if someone has a multiple drug regimen and they've been taking part of it for some consistent piece of time, or if they have a single tablet regimen, but they've been taking it on and off consistently in chunks of time that allow for the virus to be around but never quite suppressed, and so that might promote the development of resistance. So we send 2 tests looking for resistance to our different drugs. We have a separate resistance genotype specific to the integrase inhibitors, and all the other drugs are included in the first HIV genotype. And when we're choosing a new regimen, we would use those test results to try to include 3 active agents. And when we're treating patients with antiretroviral therapy, generally, patients do very well, but we do see that patients with HIV are still at an increased risk of complications, even when they're taking antiretroviral therapy. So we still see higher risk of cardiovascular disease, of malignancies, especially those that are listed here, and then, of course, potentially toxicities of antiretroviral therapy when they're taking antiretroviral therapy. So in our HIV patient population, it's even more important than in patients without HIV that we're really proactive about trying to decrease any modifiable risk factors for cardiovascular disease, such as smoking cessation, weight management, glucose management, and controlling blood pressure, those type of things. And off antiretroviral therapy, if patients either are unable to take their medications for whatever reason, and therefore have progression to low CD4 cell count, or if they just haven't been diagnosed yet, so they're not aware of their status and therefore may have progressive HIV-associated disease to low CD4 cell count, so to AIDS, then they could be at risk for opportunistic infections, the development of malignancies, or of HIV-associated dementia. And these are a couple of such cases. These are both cases of patients who were in their 40s who had never been tested for HIV previously, and didn't actually get any HIV screening throughout any primary care, and didn't get tested until they presented with opportunistic infections that nearly killed them both. And these are just a kind of a little list of some opportunistic infections that you might see at different CD4 cell count strata. So on the left panel here, this is a patient who developed toxoplasma encephalitis, so had a reactivation of latent toxoplasma infection in the brain in the setting of the development of AIDS due to HIV progression off therapy, because he had never been tested before, and developed significant brain edema that nearly killed him. He did quite well, fortunately, started toxo treatment with IV and then oral antibiotics, and then antiretroviral therapy. He walks with a limp still, and he does have some cognitive dysfunction that's relatively mild, but he's overall doing quite well, which is great. And this is a patient who was also in his 40s who developed shortness of breath and was eventually, after a circuitous route, diagnosed with pneumocystis pneumonia associated with AIDS, and had never been previously screened for HIV, had a prolonged ICU course with many complications, but eventually recovered and is now also doing quite well, and working and living independently. So all of this could have been avoided if these patients have been tested for HIV at a younger age. Okay, one more case. So this is a 22-year-old man who's generally healthy, MSM, so he's sexually active with men. He presents for evaluation of rash and fever. He's found to have secondary syphilis. That's a good presentation for secondary syphilis, with an RPR titer of 1 to 128. He's treated with intramuscular penicillin, and in discussion, he reports more than 6 sex partners in the last 6 months, 50% condom use. He's interested in HIV risk reduction, including pre-exposure prophylaxis. So how are we going to approach this with him? So our options are A, initiate tenofovir emtricitabine today and have him come back in 3 months for an HIV test. B, do an HIV antigen antibody test today and initiate tenofovir emtricitabine raltegravir for 28 days for post-exposure prophylaxis, and then transition to tenofovir emtricitabine for PrEP. Or C, do an HIV antigen antibody test today, initiate tenofovir emtricitabine if HIV negative, return in 3 months for repeat HIV testing. Or D, test him today, risk reduction counseling, condoms, and then have him come back in 3 months if only if he's still interested in PrEP. Okay, so the answer is C, and I just have a little explanatory slide. So the answer is C because we need to get an HIV baseline test to confirm that the patient is negative prior to starting PrEP. Typically, I will give the patient a prescription for PrEP at the time that I've sent the HIV test, and just ensure that I have a way of getting in touch with them so that I can call them as the HIV test comes back and make sure that they know that it's negative and they can go ahead and start taking it. I don't want them to walk out without a prescription. And the other routine baseline blood work and STI screening is also important on the off chance that they have some undiagnosed underlying renal dysfunction or something. Once those are reviewed, then there's no reason to delay PrEP. Again, you can give the prescription same day, just make sure you can reach them to discuss their HIV testing. And they do need to be tested every 3 months while on pre-exposure prophylaxis. Other STI testing at least every 6 months, typically even potentially even more frequent depending on the patient. The other options are wrong because we don't start pre-exposure prophylaxis and then test again and then do the first HIV test 3 months later. If you miss a diagnosis of HIV at baseline, then that could be very problematic for development of resistance. And then also he has an unclear date of last exposure, so we can't use post-exposure prophylaxis without knowing how long he might have been last exposed. And there's no reason to delay PrEP and just wait for 3 months if he's HIV negative and interested. This is a great opportunity after he's just had another sexually transmitted infection to try to treat him with prophylaxis to prevent acquisition of HIV. So PrEP is one of our possible arms in our armamentarium of HIV prevention methods, and so I've listed many of the others here. Risk reduction counseling, needle exchange, and condoms. I think we sometimes overlook them these days as important measures because they're not maybe as exciting as some of our other measures, but they really are still important. It's still important to talk to our patients about ways that they might get exposed to HIV, especially talk to them about sex, and open up that conversation, because a lot of patients can actually, talk a little bit about what they assume their risk might be of acquiring HIV, and then helping them to understand what their risk really is quite important. There's a website down at the right-hand side here that I find very useful. It's a CDC website called HIV Risk. You can actually have sit with the patient and do this together as an activity, and actually enter into the website the activity that the patient might be engaging in, whether it's receptive intercourse or or oral intercourse or whatever it is, and it will actually, and the HIV status of the two partners, and it will actually give you an estimation of the HIV acquisition risk. And so it's a good opener to the conversation with the patient, especially if it's a patient who you know has had a sexually transmitted infection in the past. So that's still a great measure to help patients understand their risk and ways to reduce their risk. Needle exchange program is still incredibly important. We talked about outbreaks amongst patients with injection drug use, and barrier protection with condoms are still incredibly important for HIV prevention. And also, of course, because all of the other things we're going to talk about don't prevent syphilis, gonorrhea, and chlamydia, which are all on the rise in various risk group populations, especially mainly in men who have sex with men. So, so still really important measures. But some of the medication-associated measures that we get a little bit excited about are pre and post-exposure prophylaxis. So PrEP taking antiretroviral therapy continuously to prevent acquisition of HIV in the advent of an exposure during therapy, or post-exposure prophylaxis, taking antiretroviral therapy within 72 hours after a possible exposure to prevent acquisition of HIV from that exposure. And then prevention of mother-to-child transmission by giving a full antiretroviral regimen to a pregnant woman throughout late pregnancy in order to prevent acquisition of HIV by the newborn, which is most at risk at the time of delivery. And it's incredibly effective. We have less than 1% transmission of HIV, really close to zero, in patients mothers who are taking antiretroviral therapy effectively. And then treatment as prevention, which is also incredibly effective. I have another slide about that, which I'll show in a moment. Male circumcision, very useful in high prevalence populations because it decreases the risk of acquisition of HIV for the circumcised male by at least 50%, maybe not as useful in lower prevalence populations. And there is quite a bit of work being done to try to find an effective HIV vaccine. We're not quite there yet, but hopefully someday I'll be able to change that slide. So U equals U, actually I have a button on, I don't know, you can probably see it here, advertising this. This is a campaign by the CDC to get the word out to everybody that undetectable, so meaning patients with HIV, if they achieve an undetectable viral load, meaning that they're taking their antiretroviral therapy such that we cannot detect HIV virus at any significant level in the blood work when we do an HIV viral load. So in practically speaking, in studies, that means that the HIV viral load in the blood was less than 200 copies per ml, even though most assays will detect even lower than that. So undetectable equals untransmittable. So if patients achieve that and maintain that, then it's not possible for them to transmit the virus to someone else by any means. So sexual exposure, blood exposure, none of those things. So this is really, and this marketing kind of phrasing is all based on a number of studies that looked at this, the risk of transmission in a couple of different settings for thousands and thousands and thousands of acts of possible exposure, and found no transmission of HIV. So a couple of real world studies that were very large and very successful. So this has been a great step forward for patients understanding how that taking care of their own health can also take care of the health of those around them, and also helping to lift some of the stigma associated with HIV infection. PrEP we talked a little bit about already. This shows some of the CDC graphics and some more details if you have questions about how to go about prescribing prescribing pre-exposure prophylaxis or doing monitoring while on pre-exposure prophylaxis. The CDC sites are actually very, very good and very easy to read and understand for the details of those. But it's an effective measure. It lowers the risk of acquisition of HIV by about 90% for patients who take it effectively. And this is a little bit more about it, some of the details. The indication for using PrEP is actually pretty inclusive. And so if you're seeing a patient and you're wondering, or they're asking about PrEP, which is probably the more common situation that this comes up in, if they're wondering if they might be eligible for PrEP, really anybody is eligible for PrEP if either the patient or the provider or together, they've decided that there is somehow a substantial risk of acquiring HIV by whatever risk manifestation that might be appropriate for that patient. And so if you decide, or the patient or together in discussion decide that it seems that PrEP would be useful for that patient, then you can consider them eligible and go forward with the prescription. It is a measure, a treatment measure that it's not perfect. It doesn't fully prevent the acquisition of HIV, but it is incredibly helpful at reducing the risk of acquisition of HIV, which otherwise is an incurable and potentially fatal infection. And PrEP also doesn't treat other complications of unprotected sex or prevent them, doesn't prevent acquisition of other STIs, and it has some low potential risk of side effects due to the exposure to the medication. But I think of all of that framework as being not unlike the oral contraceptives, and we understand them to be very, very helpful in a related setting, and so it's worth discussion for many patients. And post-exposure prophylaxis, again, within 72 hours of a possible exposure, so unprotected sex, whether consensual or not. This is something that would be eligible for a patient to take a 3-drug regimen, so a fully suppressive antiretroviral regimen, ideally, for 28 days. This is all based on very, very, very limited data. It's probably overkill for most patients, but there isn't really a good opportunity to get data for a smaller regimen over a shorter period of time. And this is really, for many patients, is fairly non-toxic and easy to do. So this is the regimen that we use. So despite all of those advances in care, in testing, and prevention, we still have this incredible disparity, and I think this will come as a surprise to no one, that we have disparities in HIV acquisition and HIV care, similar to disparities, racial and ethnic disparities, similar to those found in many other areas of medicine. But I think that these data are really striking. In 2016, so not that long ago, the CDC put together a lifetime risk score of HIV diagnosis based on risk categories and race and ethnicity. And when they looked at African-American men in 2016 in the United States of America, they could estimate that African-American men had a 1 in 20 lifetime chance of acquisition of HIV. Which is just unbelievably high. It is actually much higher than that for white men and white women, but those are also relatively high. You know, we are still seeing around 40,000 cases per year. So this is an epidemic that really is ongoing. Why is there's such a disparity? This is a bit more granular than we have time to talk about much, but I will encourage you to take a look, especially as we're all rethinking disparities in many different situations in these active times, that, you know, there are many different ways in which the way that our social structure is put together, the way our healthcare structure is put together, many different socioeconomic factors that contribute to these disparities in acquisition of HIV and risk of complications. And just to put it an even more finer point on this striking data, amongst men who have sex with men, even the lowest risk group out of all of them, white MSM, a 1 in 11 lifetime risk of acquisition of HIV or diagnosis of HIV, and African-American men who have sex with men, 1 in 2 can expect to be diagnosed with HIV in their lifetime. This is as of 2016 in our country. So we have a lot of work to do. These are patients who need we have discussion of their risk, have HIV prevention, HIV testing. And we will keep working at this. So that's all I have to cover today. I hope that was really helpful for everyone, and I hope everyone's staying safe and healthy. Thank you.